We can start the webinar.
Starting.
Sai, just switch on.
Yes, sir. Done.
Tell me when you're ready to go.
Connecting to cloud. Yes.
Yes, cloud started.
Live, sir.
Should we start, John?
Yes,
Yes,
sir.
Yeah, we are live. We are live.
Good evening and welcome to the second edition of the Skills in Ophthalmology webinar organized by the Department of Ophthalmology, Srihar. I request our HOD of Ophthalmology and Medical Director of Srihar, Professor Suhas Prabhakar, to open this edition of the CME and welcome all the speakers. Over to you, sir.
Thank you, Dr. Narayan. So, dear postgraduates, junior ophthalmologists, senior colleagues who have joined us, good evening to you all. I welcome you to the second webinar on skills in ophthalmology conducted by the Department of Ophthalmology, Sri Ramachandra Medical College, Institute of Higher Education and Research. The first edition of the webinar series aimed at equipping postgraduates and young ophthalmologists in basic skills in ophthalmology was a rousing success and was well received. The success of the first program has encouraged us to up the ante and raise the bar when it comes to webinar-based skill transfer. This evening, we have three eminent ophthalmologists with us who have distinguished themselves in the field of ophthalmology, constantly pushing their boundaries for excellence, and their achievements are inspirational. At the outset, I would like to thank Dr. Ronnie George for joining us today. Dr. Ronnie, or RJ, as he is popularly known, is the Director of Research and Deputy Director of Glaucoma Services, Shankar Nethralaya, Chennai. He is also part of the Advisory Board for Research at Glaucoma Research Association. He has been actively involved in research work with over 150 publications in national and international journals, pioneering the Vellore Chennai eye study in glaucoma. He has also trained many postgraduates, which we are also benefited from, fellows and optometrists alike. It is indeed our privilege, sir, to have you, and to have him with us this evening. I extend a warm welcome to him and hope all of you will benefit from his talk on optic nerve head evaluation in glaucoma. I also welcome Dr. Bhaskar Srinivasan, who is a senior consultant in cornea and refractive surgery at Shankar Nethralaya, Chennai. Dr. BSN, again as popularly called, is a former graduate of AFMC and Shankar Nethralaya, has served as a distinguished faculty in Department of Cornea at SN, Chennai for over 15 years, and has been keen interest in ocular surface disorders, keratoprosthesis, and refractive surgery. He has authored over 65 publications in the same. He has chaired several national and international conferences in ocular surface diseases and taken keen interest in training postgraduates in surgical and medical management of corneal disorders. I welcome him to give us a talk on basics of corneal topography. Last but not the least, I would also like to welcome my good friend, a teacher of repute, a constant name in all scientific forums, both national and internationally, Dr. Arup Chakrabarti, who is currently serving as the Director of Chakrabarti Eye Care Center, Kerala. He is also the incoming President-elect of KSOS for 2021 and editor at Proceedings AIOS. He is a passionate teacher and has conducted over 210 instruction courses at various international conferences as an instructor and chief instructor. He has been elected as a member of highly prestigious and exclusive International Intraocular Implant Club in 2015. So he has been awarded this AAO, American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology, and American Society for Cataract and Refractive Surgery, and has edited 3 textbooks in cataract surgery and complications. He will be talking to us on preoperative diagnosis in cataract surgery. So again, I extend a warm welcome to all speakers and wish this CME a grand success. I hope all of you all are enriched and enthralled over the next 1 hour and carry forward with you the learning of today to better informed practice. Thank you. Thank you, Narayan, for giving me the time.
Thank you very much, sir. I now request Dr. Arvind Babu, sir, who is the organizer of the CME and who's been at the forefront of this entire CME program, whose brainchild the CME was for training of postgraduates, to give us an update about this first CME and the way forward for all of us.
Thank you, Dr. Narayan. Are you able to hear me?
Yes, sir.
Good evening, everyone. This is just a small update regarding our webinar 1, which was conducted on the same day last month, which was received very well by postgraduates and young ophthalmologists across India. It was also aired simultaneously in Zoom and YouTube, like this program. The Zoom link had more than 200 participants, and our YouTube views have crossed more than 600 till date. We were very happy that we got a good feedback, particularly from postgraduates from all the colleges all over India. So if you have any suggestions regarding the topics for the future CMEs, or you want anything else extra from us, please feel free to put it in the chat box. And we're also planning a PG update very soon, and we'll be telling you the details in the future. Thank you. Over to you, Narayanan.
Thank you very much, sir. I request all the participants to just keep their mics muted throughout the duration of the CME. And also, if you have any questions, please put it in the chat box so that we can put it out to our speakers as this program goes. And at the end of each talk, we will take the questions for the respective speakers. Our first speaker for the evening is Dr. Ronnie George. Sir is the Director of Research and Deputy Director of Glaucoma Services in Shankar Nethralaya and is a legend in the field of glaucoma. His academic prowess and achievements deserve a CME of its own, and introducing him prior to a talk is harder than implanting an AGV in a pediatric refractory glaucoma. Sir has been an inspiration to many young glaucoma specialists and postgraduates across the country. His interest in epidemiology and a population-based approach to glaucoma has laid the foundation for many of our practices. I request you to take over, sir.
Thank you, Narayan, for the kind invitation and the very kind words. Also like to thank the entire SRMC team for inviting me. Just a minute. Yeah, can you see my slides?
Yes, sir.
Okay. Okay, so I'm going to cover optic disc evaluation, the basics with you today. And basically, the optic disc evaluation is really important because optic disc changes precede visual field loss. And in fact, it's probably the most accurate way of detecting glaucoma that we have. Also, don't forget that 20% of ganglion cell loss occurs before the development of a 5 decibel defect on automated perimetry. And a careful evaluation of the optic disc could even help you to detect preperimetric disease. And how should you evaluate the optic disc? Today, the gold standard is slit lamp biomicroscopy using a 60 diopter, 78 or 90 diopter lens. And this is the way forward that you should use to evaluate the optic disc. And don't forget that when you use one of these lenses to look at the disc, you get a real inverted laterally reversed image, and you should keep this in mind when you're describing it. There are 5 R's which you can keep in mind while assessing the optic disc. Observe the scleral ring to identify the limits of the optic disc and its size. Identify the size of the rim. Examine the retinal nerve fiber layer. Examine the region of peripapillary atrophy, and look for retinal and optic disc hemorrhages. If you follow these 5 steps in detail, you will not have trouble identifying a problematic disc. So the first step is to identify the scleral rim. And the scleral rim is basically the edge of the disc, and it is, you can see that as a faint sort of slightly elevated ridge there, and that is how you identify that. Once you identify that, you should try and measure it, and you can measure it using the slit lamp graticule that you have, and depending on which lens you have used, you need to put a multiplication factor there to assess what the vertical or horizontal height is. Why is measuring the optic disc size important? And that is because these 3 discs are all normal, and you can see how different the neuroretinal rim and the cup looks in all 3. They are all normal, and the difference in neuroretinal rim and the cup is just because of the difference in disc size. Size matters because while the number of ganglion cells does increase marginally in a larger disc, it doesn't increase very much. It just ranges between 800,000 and 1.2 million, and the disc size varies much more than this. This is some data from the Chennai glaucoma study that I'm showing you here. And from our population-based study, a subset of patients underwent planimetry. And here you can see what happened to the mean disc area in the smallest group versus the largest disc size group. And you can see what happens to the mean vertical cup to disc ratio in this entire group. You can see that in the smallest group, the mean vertical CDR was about 0.2. In the largest group, it was about 0.5. And both these are absolutely normal for that patient. The optic disc is a bit problematic because there's almost no other organ in the body which has this much of variation in size. In the normal population, disc size varies by a factor of almost 800%. And that's the reason assessing abnormality in the disc without accounting for size makes life a little difficult. So once you have assessed the disc size, the next is to identify the size of the rim. And this is this is actually the crux of glaucoma disc evaluation. When you're looking at the rim assessment, there are two ways that you can do it. You can either look at the contour of the rim or you can look at the rim color. Most of us tend to first look at the color, and some of us continue to pay attention to only the color, and that is a little problematic. I'll come to that a little later. So this is identifying the scleral ring, and the neuroretinal rim optic cup border is taken as the level at which the slope of the rim steepens or where the vessels deviate. And this is the extent of the optic cup. And you can see that over here, this vessel has turned, this vessel has moved, has curved, and this is the area of the optic cup, and that's how you would mark it. So when you look at this disc, just take a quick look. This is where the color cup is. And you would think that, oh, this is fairly okay. That's a fairly decent looking disc, and you leave it at that. But if you follow those blood vessels, you can actually see that they're changing direction here. And this contour cupping is what is important for us. So when you look at the color cup versus the contour cup, you can see that the cup is much larger than what you first thought it was. And this is also has a superior nerve fiber layer defect there. And this is definitely a glaucomatous disc. If you do not look at it closely, this can become problematic. Also keep in mind that this is a small disc, and in a small disc, you would expect to see a small cup. So a small disc with a largish cup is again something that you should look at suspiciously. Once you have identified the neuroretinal rim, see what is the pattern. And this is a typical pattern of the neuroretinal rim, that the inferior rim is thicker than the superior rim, which is thicker than the nasal rim, which is thicker than the temporal rim. Keep in mind that no portion of the optic of the neuroretinal rim should be thinner than the temporal rim. That's another parameter that you should try and remember. A good majority of normal optic discs will follow this pattern. Almost 75 to 80% of normal optic discs will follow this pattern. And the reason that they follow this pattern is because it depends on the position of the central blood vessel trunk. So as you can see over here, the central blood vessel trunk is here. And as you move away from that trunk, you can see larger lamina cribrosa pores. This is because the connective tissue is most dense close to the level of the vessels and gets less dense as you move further away. And that is the reason why the rim follows this pattern. So you have the superior and the inferior, which have the worst lamina cribrosa, which have less lamina cribrosa support, and therefore you have more damage in these areas. And these are the areas which you need to look at carefully for neuroretinal rim changes. Keep in mind that if you have a highly myopic disc or a tilted disc, you will not have a normal optic disc ISNT rule. So once you have identified the borders of the cup and the rim, now then you look and you have identified the contour, you look for localized changes. So you look for excavation which is local, like over here, and you can see that you are seeing some thinning there. It is not reaching the edge of the disc, so this is an incomplete notch or a focal thinning. Here you are again having excavation which is coming almost all the way to the edge. And here you have complete loss of the neuroretinal rim locally there, and that's a complete notch. So this is the way that you would classify the neuroretinal rim lamination. Don't forget, in each of these situations, this area is thinner than the temporal rim. What about concentric thinning? Concentric thinning is the other thing that can happen. And if you look at carefully at the whole disc looks a little pale, but if you look at the contour of the vessels, you can make out that there is concentric rim loss. And this is also another way that it may present to you. Cup disc asymmetry is important. And here you have somebody with a small cup in one eye and a fairly large cup in the other eye. You're also seeing a disc hemorrhage and a nerve fiber layer defect. But when you look, if you look just at the cups, there's definite asymmetry, and cup disc asymmetry is rare. You see a difference of more than 0.2 and less than 5% of normal eyes. So this is another set of eyes with cup to disc asymmetry. But once you look at the disc size, and you notice that the disc on the right is larger than the disc on the left, Therefore, you would expect a larger cup here. The importance of the cup to disc asymmetry comes down a little bit. So what is important is that you, whenever you're looking for cup to disc asymmetry, also assess disc size. And this is basically the disc size measured here, which is 1.86 millimeters vertically and almost 3 millimeters square cup on the left, while in the right is just 1.57 millimeters and just 2.4 millimeters square area. So important when you look for asymmetry that you assess disc size also. What about pallor? A pale rim increases the likelihood of a non-glaucomatous optic neuropathy. We all know that, but sometimes the pallor is a little subtle. For example, this pair of discs that you can see here, this looks fairly healthy, and this one looks a little bit pale, especially here. And this is something that should always be looked at with a high index of suspicion. And sure enough, when you do a visual field, you do see a hemianoptic defect there, and you see a pituitary tumor. So this is something which is not glaucoma, but again, the presence of pallor should be investigated for. So once you have finished identifying the size of the rim, next, and the neuroretinal rim pattern, look for the RNFL or the retinal nerve layer. When you're looking at this, it's best looked at with a red-free light. Look for brightness, look for striations, look for visibility of peripapillary blood vessels, and look for diffuse or localized nerve fiber loss. So this is a normal pattern. You get a bright pattern here. The area next to the macula is dark, and you get a bright zone below. And a retinal nerve fiber defect would show up as a dark area in a bright zone. So here you have an eye with a superior notch, and you can see a large white retinal nerve fiber defect there. And this is a little more difficult to appreciate on the red-free, on the color photograph, but once you put in the red-free, you can see a local small wedge-shaped defect inferiorly. And this is why it's important to either look at it with a red-free filter on the slit lamp, but it's best viewed on photographs most often. Next, examine the region of peripapillary atrophy. And this is something that you need to look at because you have a beta zone, which is increased visibility of the larger choroidal vessels and sclera. This is because of the atrophy of the choriocapillaris. And you have the alpha zone, which is irregular hyper and hypopigmentation of the RP. Alpha zone is fairly common. So progressive increase in the area of peripapillary atrophy can be a sign of increasing damage. And this is something that you should keep in mind. So this is why it becomes important that when you look at an optic disc, you document it, either do a drawing or mention that is peripapillary atrophy, or mention where the retinal thinning is. Ideally take a photograph, because photographs seen serially can give you a number of clues. So here what you're seeing over here with the green arrows is the extent of the alpha zone, and what you're seeing with the yellow arrows is the beta zone. So the beta zone is because of exposure of the choriocapillaris, and it's lightly pigmented, while the alpha zone is the slightly dark pigmented zone over there. Look especially carefully at the inferior and superior neuroretinal rim area. If you see any localized notching there, then you need to look at it in greater detail. So peripapillary atrophy here, again, you can see alpha zone with a localized beta zone and some amount and a little bit of a slope there. The last R that you look for is for retinal and optic disc hemorrhages. And these are fairly specific for glaucoma and should be looked at carefully. They often disappear within 1 to 3 months, and they indicate glaucomatous progression. So this is again one more of Jonas' rules. He says all eyes have a retinal nerve fiber defect until proved otherwise. And unless you look for it, you will not see it. Now here is fairly classic. You're seeing a retinal nerve fiber defect as well as a disc hemorrhage. And this area, if you look at in future, you will find that the RNFL defect would actually widen a little bit. So whenever you're looking at the optic disc hemorrhage, you need to look at it as a complete picture. So look at the rim, look for peripapillary atrophy, look for localized thinning. You're seeing a retinal nerve fiber defect, a disc hemorrhage there, and possibly a thin RNFL defect there. So a careful systematic assessment of the disc applied in the clinic using all the 5 R's is actually helpful in identifying early glaucomatous damage. Note that I have not spoken about the vertical cup to disc ratio at all, because the vertical cup to disc ratio is dependent on disc size, and it's literally the last thing that we would think about. What's much more important is that you look at each of these parameters in detail and describe the disc accordingly. Thank you, and I'll be happy to take any questions.
Thank you for the fantastic talk, sir. I think we do have a couple of questions from the postgraduates. First question is, does disc area influence glaucomatous damage and its progression in any way? Do we have to, I think he's trying to ask if you have to assess the disc a little differently. When you have a larger or a smaller cup, would you want to do anything differently as per the disc size, if that's what?
Yes, I mean, one of the things is disc size does not affect glaucomatous damage and its progression. But what does happen is that if you have a small disc, you would expect to have a small cup. So if you know that the disc is small and you're seeing anything more than a small cup, look very, very carefully. If you have a large disc, you expect to see a large cup. But don't just assume that because it's a large disc, it's going to have a large cup, therefore it's probably physiological. Look carefully at the neuroretinal rim. Disc area on its own is not really associated with an increased risk of glaucoma. It is confounded a little bit by myopia because myopia is associated with slightly longer eyes, slightly larger discs, and myopes are a little more prone to have glaucomatous damage.
So there's also there's some correlation between disc area and CCT in certain things where there's some inverse relation. Does it actually confound your glaucoma progression, as in you want to look at it more closely when you have a larger disc area, and because there's an inverse correlation? How do you do about that, sir?
So essentially, when you look at central corneal thickness and the risk of progression, you're basically looking at the risk of progression mostly among ocular hypertensives because of the issues with assessing IOP. Once you have established damage, and unless you have very low CCTs, CCT as an isolated factor that contributes to optic disc progression has not really been proven.
Right.
Partly because of the reasons that you just said. You have a large eye, you may have a little less central corneal thickness, you may have you may have less globe rigidity.
Right.
And therefore you may have a slightly more susceptible disc. So having said that, any myopic disc should be looked at carefully, and always keep CCT in mind. You don't need to actually formally correct for the CCT, but keep in mind that this person has a thinner CCT and therefore maybe globe rigidity is a little lower.
We have another question. Sir, can you please tell us what's the best way to differentiate between a myopic disc that is not glaucomatous and one that is glaucomatous? I think this is the biggest problem most of us have in assessing myopic disc with very shallow cups usually. That's what he's trying to.
I will share a secret with you. I have the same problem. So all of us have the same problem because these are essentially myopic discs are very often slightly abnormal. They're large, they're shallow, they're slightly tilted, they have peripapillary atrophy, or they're sitting in a coloboma. So it becomes pretty difficult to look at what is happening. Again, you have to look at the neuroretinal rim carefully. You have to do a good red-free RNFL examination. Ideally, draw the disc. In fact, ideally take a disc photograph. Because myopic eyes, especially people with progressive myopia, you're going to have retinal changes in addition to the disc changes. And the only way you will be able to figure out a structure function correlation is if you know what it looked like before. So definitely do a good disc evaluation, take a photograph, and look carefully for the extent of neuroretinal rim thinning and peripapillary atrophy. Don't assume that every myopic disc is glaucomatous, but very useful to take a photograph and keep it with you. And tell the patient to keep it carefully because this is going to be a problem every time they come to see you.
But with a tessellated fundus with severe chorioretinal atrophy in general in the retina, it becomes harder to look at the RNFL also. No? So when we are looking directly evaluating, so how would we go about those ones? Does the bending of the vessel help more significantly than?
So whenever you look at these discs, at any disc, you basically look for a contour change. Look to see whether the blood vessel is changing. Don't look for the pallor. Right. And even in shallow cup, you can sort of pick up when the vessel is bending. Having said that, because these are large myopic discs, you may not always, the anatomy itself is a little abnormal. Right. And if there's a little bit of tilt, you'll see all the vessels also changing. Right. So that becomes a bit tricky. Assessing it with a red-free is a little bit more difficult. Sometimes if your indirect has a red-free attachment to it, you may be able to appreciate the difference more. Ideally, take a disc photo, take a red-free photo. So for us, our protocol is if you're taking a disc photo, we take a red-free photo too. Yes. And sometimes if you push the contrast a little bit, you can appreciate a subtle NFL defect. But get it done because it will help you if the disc progresses.
What is the best way to follow up on high myopes, especially if they are glaucoma suspects, especially when we have confounding changes on the visual field because of myopia? And is OCT reliable for myopic patients?
Okay, so the best way of doing this is to get as much information as possible, and that means getting good, baseline IOPs at multiple times of the day, getting a good disc photo, preferably pseudo stereo, getting reliable perimetry, even if it shows defects, as long as it's reliable and consistent, that's fine. And getting an OCT is not a crime. Don't worry too much about what the OCT is showing you, because an OCT of a myopic disc is likely to be abnormal because it is being compared to normal discs. But it's important to you from a progression point of view. So the more information you have, the more comfortable you'll be deciding whether there's progression or not. If you're seeing progression on both structure and function and not seeing anything on the retina to account for that progression, it is glaucomatous damage. So document well, and that is the main thing that you can do.
You'll always be a little more aggressive in treating a myopic disc with other confounding factors like a thinner CCT and maybe older age, more than maybe say a person who's not as myopic, the disc is not as much. Would you be a little more aggressive in your treatment, sir?
Not necessarily. I mean, there are two things to it. Now, one, if I definitely have an elevated intraocular pressure and a glaucomatous optic disc damage, then I would consider treating. I would consider treating similar to the other eyes, because there is really not any evidence that myopes progress any faster than non-myopes. So based on evidence, there's no reason for us to treat them more aggressively, but make sure you follow them up well, get to their target IOPs, and alter it based on whether they progress or not.
All right. So I think it's a simple one. What is the best way to assess the optic disc? I think for the postgraduates, what would be the best way to start?
Size, sir.
Yeah,
optic disc size, size.
So clinically, the best way to assess the optic disc size is at the slit lamp using the 60, 90, or 70 diopter lens. So you can use the slit lamp graticule to measure the vertical height of the cup. And based on which company's lens you're using, there are multiplication factors available to you, which you can just multiply to give you the vertical height. If you really want, you can do the vertical height, you can do the horizontal height, and then you can actually use the ellipse formula if you want to calculate or have a rough idea of the area. But a vertical height calculation is enough, because that will give you an idea as to what is the normal size of the disc. And if you do this on, let's say, the next 100 patients that you see, you will have an idea for the disc size distribution in your population.
Sir, I think HOD has a question. How do you evaluate glaucomatous changes in a tilted disc? Do we really rely on evaluating measures when you have a tilted disc?
So this is again actually a very difficult situation, because sometimes when you have a tilted disc, you can also have a few scattered visual field defects. Because when the disc is tilted, the nerve fiber layer bundles also get tilted. And therefore, when you're comparing it with a normal disc on the visual field, it is following on a pattern on a portion of the visual field where there are not that many ganglion cells, because that's the anatomy of that eye. So when you're looking at a tilted disc, again, documentation in terms of good disc photograph, good baseline visual fields, and even an OCT. Because whenever you look at an abnormal disc, all your parameters that you're looking at, a visual field or an OCT, are likely to be abnormal, because these are based on normal discs in the database. So looking and documenting a disc photo is probably the most important thing that you can do here, because a change on a disc photo doesn't occur without pathology.
Also, we have another question. Is the reversal of the ISNT rule always mean that the disc is glaucomatous? Can we have a normal reversal in some cases?
Yes. So about 80% of eyes, of normal looking eyes, would follow the ISNT rule. In about 15 to 20%, you would actually not see that. So the ISNT rule is a guideline. Don't think that that's the only thing that matters. But any disc which does not meet the ISNT rule needs to be looked at a little bit more closely.
What would we do, sir, when you want to determine that it's non-glaucomatous and it's just a reversal of the ISNT rule?
Yeah. So
do we do fields and OCT thereby? I
mean, these are all discs which are disc suspects. If you have a 22-year-old with normal IOPs and a disc which looks slightly reversed like this, then the chance that this person has pathology is minimal, especially if all the other 5 Rs are okay. it's a reasonable size disc. The RNFL is okay. There are no disc changes. I mean, there are no RNFL changes. There are no peripapillary atrophy. You can probably just even assess clinically. But if it's the same picture in somebody who's 70 years old with a slightly borderline IOP, then do all the investigations, get documentation done.
I think that's the last question, sir. Thank you so much for the fantastic talk. We've all learned a little more about the optic disc, but it'll always cease to be our biggest problem in assessing glaucoma. Thank you so much for that talk.
Thank you, Narayan. Thank you for the kind invitation. It's been a pleasure.
So, our next speaker is Dr. Bhaskar Srinivasan, Senior Consultant in Cornea, Ocular Surface and Refractive Surgery at Shankar Nethralaya, Chennai. Dr. BSN, as he's popularly known, is a former graduate from AFMC and Shankar Nethralaya and has served as a distinguished faculty in the Department of Cornea at Shankar Nethralaya, Chennai for over 15 years and has a vast experience in lamellar keratoplasty, keratoprosthesis, and refractive surgery. Dr. BSN is a teacher par excellence and is a mentor for many aspiring corneal surgeons. He has a never say never attitude and is the go-to guru for all postgraduates and cornea fellows in Shankar Nethralaya. I request you to enlighten us also.
Thank you, Narayan. And I would like to thank the faculty at SRMC for giving us the opportunity to present what we do and to learn along with all of you all. So am I audible? Can you see my slides?
Yes, sir.
Yes, sir.
So I've been asked to speak on corneal topography. So basically, we are looking at investigations to look at the corneal shape and to look at the corneal power. So what are the investigations that we have? We could either use a keratometer, we could use a Placido's disc, we could use the Placido's disc with a video topographer, or you have the older versions of the scanning slit, that is the op scan. What is commonly used these days is the Scheimpflug based devices, basically either the Pentacam, the Cirrus, or the Galilei. You could have a combination of an aberrometry based device along with a Placido like the iTracy, or you could now have something which is OCT based, which gives you the OCT along with a Placido's disc like what is there in the ML39, giving you the complete anatomy of the cornea and the anterior chamber. Why do we need a corneal topography or a tomography? Basically, we would need it as a pre-operative evaluation tool for a pre-refractive surgery patient, for a post-refractive surgery patient to know what has happened, and if it's an unhappy patient to know why the patient is unhappy. If it's a post-LASIK patient and he wants to undergo a cataract surgery, we would need to get topography done. Some of the topographers also help us with tear film evaluation. Patients with a scarred cornea, or patients with keratoconus, or with irregular astigmatism due to various reasons, we would need to evaluate them in detail before we can help them with different modalities of treatment. So these are broadly the indications for which you would get a corneal topography done. So the video keratoscopes, basically, which was the first generation video keratoscopes, involved shining the Placido's device light on the cornea and taking the reflection from the tear surface and then using computerized algorithm to give you the curvature of the cornea, and this is then converted into the refractive power. So when you're talking of topography, there are certain things that you need to know. What do you mean by radius of curvature? So when you mean when you look at the radius of curvature, there are two radius of curvature in a topographer. One would be a global radius of curvature, which basically looks at the curvature of each point with respect to the optical axis. And the other is the local radius of curvature, which looks at the curvature of one point with respect to the adjacent point. This is important because this is how we differentiate between an axial map versus a tangential map, and I'll come to it later on. Coming to power, we with respect to the topographers, we do not calculate the power directly. We are just taking the curvature and then using a standard keratometric index of 1.3375. So here we are not utilizing the back corneal power in the calculation, and we are just giving you a fudge factor to give you the total corneal power. And this is derived by assuming standard thickness, refractive index, and shape of the posterior corneal curvature. So this is why when you have had a patient who has undergone laser surgery or LASIK, you cannot use the standard formulas in the normal manner and get your IOL calculation done. Height, the Placido's device don't give you height as accurately because it's only an extrapolation of the data, but the others like the Scheimpflug image cameras can give you a better evaluation of the height. Basically, this tells you how steep or how flat the respective surface is with respect to a standard. It could either be a flat, it could be a curved surface in the form of either a sphere or a toric ellipsoid. And coming to the display maps, commonly most of the topographers use the hot colors indicating a steep area, the green colors indicating an intermediate area or a normal area, and the cool colors, the violet or the blue, which indicate a flat area. So when we look at a topography map, what is the first thing that we would do? The first thing would be to always check the name and the date and the eye which you are dealing with, because if you are not looking at that, you might sometimes misinterpret the data. The next would be the machine, because the data of the same patient in different machines can also be slightly different. It might not be the same. The third would be to look at the scale. So you're looking at either an absolute scale or a relative scale. Also, you need to look at the steps which are there, because the color coding is dependent on this distribution of the power in the maps. So if you look at the types of scale, what we talk about is an absolute or a standard scale, where you have the lowest power, say in a particular machine is 9 diopters and the highest power is 101 diopters. The colors are distributed across 9 to 101. So you will always have the same color indicating a same power of the cornea. So it is consistent. It allows a rapid and direct comparison between maps of one eye with the other eye. And it becomes easier because we are used to seeing the colors. However, if there are minor irregularities, since the colors are distributed over such a wide range, you might miss the minor irregularities. But as a general rule, when you're looking at a pre-refractive surgery patient or as the first map of a patient, it would be better to just do the absolute or the standardized scale. And once you have seen the map and then you want to go into more details, you look at the normalized scale. A normalized scale basically divides the patient's own power from the color is distributed between the least and the maximum power in that particular cornea. So if you look at the absolute scale, this starts at 9 and it goes to 101. So this looks fairly normal. And this is what we are used to seeing regularly. But the same scale, if you put it in a normalized scale, the same eye, this looks much more red. And sometimes if you are not looking at this, you might actually misinterpret it as a very steep cornea or probably keratoconic cornea. So it's important to know that what is the type of map that you are dealing with respect to the normalized or the absolute scale. Coming to the types of map, you have the axial or the sagittal map, and this basically takes the data from the first to the next string, and it is based on a spherical based algorithm. It assumes the cornea is spherical. So it looks at the curvature of one point with respect to the curvature in the center and describes the overall shape of the cornea. So this is similar to what I said of a global radius of curvature. And then you have the tangential or instantaneous map, which basically takes the curvature of one point with respect to its adjacent point. So it gives you a much better geographic representation of the cornea. So subtle differences between adjacent points get better reflected in a tangential or an instantaneous map as compared to a sagittal map. So if you look at this patient who's undergone laser refractive surgery, if you look at the map on the left, it looks fairly normal. You can't swear and say that the patient has had a refractive surgery because it doesn't give you as much clues. But the moment you put a tangential map, the peripheral untreated area shows up as steep and the central myopic ablated area shows up as flat. So this transition is much better seen in an instantaneous map as compared to an axial map. So you would still do the axial map initially, but if you want to look at centration of your laser refractive procedure, or you want to look at the diameter of your treatment zone, an instantaneous map is much better. Elevation maps, like I said, from a placido-based device, it's not that useful. It gives you some idea in terms of refractive surgery, because refractive surgery, the treatment is by ablating tissue, so thinning the cornea or flattening the cornea. So it can give you some idea as to what was the treatment done. But this is an extrapolated data as far as the placido-based device is concerned. So it is much better when you use this in Scheinflug-based devices rather than a placido-based device. Then you also have the option of subtraction map. So if you have done a procedure for a patient, say a suture removal, you can compare the pre-suture removal topography with the post-suture removal topography, and that shows how much the suture was affecting the astigmatism and how the cornea has changed pre and post procedure. The next part would be to look at the topographical pattern. So this is like a regular bow tie. But if you look at it, there are almost about 10 patterns that you could see. You could either see a round or an oval, superior or inferior steepening, irregular, symmetric or asymmetric bow ties with a skewed radial axis. So you need to have an idea about the different patterns, because some patterns are more suggestive of a probable keratoconus, and you will need to look at those maps a little bit more carefully. So this is a classical round pattern, which is seen in about 20% of the population. This is an oval pattern in about 20% of the population. This is a regular bow tie seen in about 18%. And this is an asymmetric bow tie, which is the most common, as seen in about 32% of the normal population. In absolutely irregular astigmatism can be seen, especially if the patient has undergone any laser refractive procedure which has had a complication, or he's had a penetrating keratoplasty, or he has a corneal scar. The next would be to read the statistical information which is given at the bottom. So it tells you about the cornea, the parameters of the cornea in a little bit more detail. So you have got something called as a CME, which basically is the keratometric equivalent at the 3 millimeter zone, and it takes the values between the 7th to the 9th Meyer. It gives you the axis with the greatest power, and 90 degrees to that is the axis with the least power. It also gives us the minimum K value and provides the axis where the keratometric value is least, and it averages the maximum and the minimum value and gives you an average K. And it also tells you what is the topographical cylinder in that cornea. This is important, especially when you're dealing with a patient who requires a toric IOL. You also have indices which help you in understanding how regular the cornea is. The surface asymmetry index basically takes into account differences between points which are 180 degrees apart. And if the difference between both those points are more, it indicates that the cornea is more irregular. So it is much higher in patients with keratoconus, post-transplants, decentered treatment, trauma, or contact lens warpage. Similarly, a surface regularity index is also similar, but it looks at points within the central 10 Meyers. So it is basically looking at the difference between, say, the superior and the inferior points, but within the central 10 Meyers. So this is going to affect your vision a little bit more. And based on the SRI, you also have something called as a PVA, which is written, which is basically a potential visual acuity of that eye. And again, this value is higher with irregular astigmatism. So both SAI and SRI, if they are high, indicate that the cornea is irregular. You also have a value of asphericity, which basically indicates the shape of the cornea. A prolate surface has a negative Q value and an oblate has a positive. The normal cornea has a prolate shape, which is about -0.26. An ideal aspherical surface would have a Q value of -0.52. And most machines make our life simpler because they have their own keratoconus screening indices, either the Smollett Kleist index or the Kleist Meda or the KISA. So different indices will be there. So it helps us identify keratoconus patients much easier than having to remember all the indices ourselves. So when you're reading a topographic display, it is very important to first evaluate a patient on slit lamp. The topography is going to give you an abnormal or a normal cornea based on what image the machine is seeing. But a patient with a scar, the machine might say it is keratoconic because the curvature is changing. So always, before you give a diagnosis, evaluate the patient on the slit lamp, check the topography with that of the other eye, check the previous maps of the same eye before you come to a diagnosis that yes, this patient has keratoconus or this is an irregular topography due to a particular cause. So generally, when you look at one eye and the other eye, they are mirror images of each other, and this is what is called as enantiomorphism. So just coming through some examples, this is basically a central flat area, which is a well-ablated post-myopic LASIK. This, if you actually would have put the tangential map, you would have actually appreciated the decentered ablation zone a little bit more. And this is the pre and post suture removal decrease in astigmatism. The suture removal decreased from about 6 diopters to about 2 diopters. So here you would remove the sutures in this quadrant and in this quadrant. Again, an irregular inferior steepening suggestive of mild keratoconus, slightly more suggestive of moderate keratoconus. And this is a topography showing pre-keratoconus surgery and then post-DALC, the improvement in corneal topography. This shows a superior steepening suggestive of a Tyrrhen's marginal degeneration. But Placido's device, when you look at it, are based on curvature maps, and curvature maps have their limitations in terms of the area which is covered. And the most important limitation is we do not get any information about the posterior surface. We do not get any information about the corneal thickness. And that is the reason why Scheimpflug based devices have become more common. So I would basically be speaking of the pentacam. It basically gives us the corneal topography, tomography. It gives you the pachymetry and the detailed anterior chamber evaluation. So it is based on the Scheimpflug law, which basically says that if you want to get a higher depth of focus, the picture plane, the objective plane, and the film plane have to intersect at one point. And the data is given as an elevation data. So it basically gives you a reference sphere, and whether the point is above or it is below that reference sphere is shown in pictorially. You could either use a best fit sphere, you could use a best fit toric, or you could use a best fit toric ellipsoid. Now, ideally, the cornea is a toric ellipsoid, so you should be using a toric ellipsoid. But you will be using a toric ellipsoid only once you are looking at the cornea in a little bit more detail, because subtle evidence of keratoconus will be masked by the computer itself if you fit a BFTE for all patients. So ideally, when you're doing a refractive surgery clinic and you're evaluating as a primary investigation, a BFS is the best way, and all the baseline values that are given are with respect to a best fit sphere. So you have something called as a fast refractive screening map in pentacam. Then you have the classical 4-quad map. You have something called as a Bellin-Ambrosio display, and you have the Zernix analysis and the Hollidays maps. So basically, most of the data is given in the 4-quad map, but you need to look at all the maps in great detail before you take a final call on whether the patient is fit for undergoing refractive procedure. So the fast screening report basically takes a data of a lot of people, but this is not an Indian data. This is from the European and the American data, and you can easily see where this point is fitting. So you have about 12 parameters, which basically includes the anterior chamber depth, the pachymetric value, the pachymetric progression, and the steepest keratometric value. And if you see this is falling in the red zone, then you know that this patient might be having some issue in the cornea, and you need to look at his topography maps in a lot more detailed manner. So this is how a basic 4-quad map looks like. The first top gives you the date, name, and age of the patient and when the investigation was done. The next gives you information regarding the front surface of the cornea. The third box gives you information regarding the posterior corneal surface, and then you have the pachymetric and the anterior chamber details. The 4 maps themselves, you normally you can change the maps using a drop-down menu, but what is commonly done is either an axial map or a sagittal map, anterior elevation map, posterior elevation map, and corneal thickness map. Sagittal map, if you want to look at the map in a little bit more detail, you could go for the tangential map. So it is important when you're looking at any of these maps to look at abnormalities affecting the same point in more than 2 maps. So if your elevation is high in the anterior elevation, corresponding area in the posterior elevation is high, correspondingly pachymetry in that area is low. All these indicate an abnormality. So like in this picture, you can see an inferior steepening. The K value is high, 54. So yes, you are looking at keratoconus. You look at the elevation is anterior elevation is high, the posterior elevation is high, the pachymetric value is low. So this is keratoconus level 2. So if you look at this, sometimes there is a confusion whether this bird beak pattern is keratoconus or it is something called as pellucid-like keratoconus. Now, this can happen because if the cone is large and it sags, you can have a similar picture even with keratoconus. So how do you differentiate this? So if you look at the 4-quad map, the bird beak, you can see the elevation is high at the same area. But if you look at the pachymetry is thinnest is at the area of the elevation, but there is no bell-shaped change as far as the map is concerned. This is suggestive of a pellucid-like keratoconus. This is not a pellucid marginal degeneration. And the details will be more clear if you look at the Scheimpflug image. I'll come to that later. Then the other maps that you get is something called as an enhanced Bellin-Ambrosio scale, where they basically exclude the central 4 millimeters of the steepest area of the cornea, and the best fit sphere is plotted, excluding that. So any deviation is picked up a little bit better, and there are cutoff limits with respect to how much of deviation of the anterior elevation and posterior elevation would suggest an abnormal cornea. So this is what is the normal Bellin-Ambrosio display. So it excludes the 4 mm of steepest area and replots the best fit sphere map, and then it gives you the difference, and the values are here where it says if it is between 5 to 7 micron difference, it is borderline. If it is more than 7, it is suggestive of keratoconus as far as front elevation is concerned, and more than 15 as far as back elevation is concerned. It also gives us the corneal thickness profile and the percentage thickness increase of the cornea. And if this red line goes beyond the 2 standard deviations, either lower or higher, you are dealing with an abnormal cornea. It also gives you something called as a D value, and this takes into account the anterior elevation, the posterior elevation, the thickness, and the spatial progression of your pachymetric value to summate and give you a D value. A D value of more than 1.7 is suggestive of a probable keratoconus, and more than 3 is suggestive of a definitive keratoconus. So like in this case, you can see the best part of pentacam is most of these abnormal or borderline values are highlighted as yellow, and the abnormal values are highlighted as red. So you actually don't need to remember the values. The abnormal values or borderline values pop up directly on the screen. This is a patient where the bad maps initially is normal, but if you look at the pachy progression, it significantly skews down. So it is not that all the maps will be abnormal. If you have more than one particular map which is showing an abnormality, you need to look into that patient a lot more deeper. Bellin has also proposed his ABCD display, which basically takes into account the curvature of the anterior 3 mm zone, curvature of the posterior 3 mm zone, the pachymetry, and the visual acuity. And that is plotted over a period of time to give you a visual idea as to how the patient is progressing, especially prior to cross-linkage. This becomes a good tool to evaluate a progression of the condition. This was what I was talking about in terms of PMD. So we saw the bird beak appearance earlier. But when you compare that pachymetric map and you compare the pachymetric map here, it shows a little bit of a bell-shaped phenomena. So that is more suggestive of a PMD. And if you look at the Scheimpflug image, it will be clear that you have a thinning and you have an ectasia which is above the thinning, which is more suggestive of a PMD. For keratoconus, the thinning and the ectasia will coincide. Difference maps, whether in Placido-based device or in Pentacam, perform the same role, especially pre and post refractive surgery or pre and post cross linkage when you're looking at progression of keratoconic patients. Certain values that you would probably need to remember when you're looking at the sagittal map: a value more than 48 is suspicious. The skewed radial axis more than 22 is suspicious. Superior inferior difference of more than 2.5 diopters is suspicious. A corneal astigmatism more than 6 diopters is suspicious. When you're looking at elevation maps, an anterior elevation of more than 12 and a posterior elevation of more than 17 is probably a suspect keratoconus, and you will need to evaluate the maps in detail. Any island formation is suspicious, and if the anterior elevation is more than 5 at the apex and more than 7 to 8 at the thinnest point, it is suspicious. You don't need to actually remember all these values. You basically need to look at the map to show you where is the area of abnormality, where is the area of the thinning, and see if it coincides in more than 2 maps. Then you need to be careful. When you're looking at pachymetric values, value less than 470 is to be looked at a little bit more closely. A superior and inferior difference more than 30 microns, and more importantly, a deviation of the thinnest point by more than 500 microns inferiorly is a very important red sign that you should be looking at. For cataract surgery and refractive surgery, you have a cataract pre-op display by Holiday, and the Pentacam also has something called as a densitometry, which tells us the grade of cataract, and it also can tell you about the reflection from the corneal surface. There are certain things which you just need to know, something called as a true net power of the cornea, which basically takes into account the anterior and the posterior curvature of the cornea and calculates the power. This is different from the keratometric power, so you can't use the true net power directly in your IOL calculation. The EKR reading, which is the equivalent K reading, calculates the anterior corneal power, calculates the posterior corneal power, and then it says that because in a normal cornea, anterior and posterior, there's a difference of the ratio is about 80 to 20. It extrapolates that and gives you a value what a normal SIMK would give, or close to that. So you could use EKR with the normal formulas, and this is primarily useful, especially when you are looking at post-refractive surgery patients. You also have something called as a total refractive power map, which is based on ray tracing. It gives you both the anterior curvature and the posterior curvature. Again, it cannot be used directly for IOL calculations, but because it gives you the power more accurately, it is useful for toric IOLs, because you can plan the amount of astigmatism that needs to be corrected, because there is a difference when you have a with the rule versus an against the rule. And this value of your total corneal refractive power map, the astigmatism can be fed into your toric IOL calculation. So this is just a description of the holiday report, which basically gives you the same 4 maps along with certain details with respect to the EKR values, and it also tells you about the total spherical aberration in the eye and the total higher order aberration. So if you're looking at this one map and you see the spherical aberrations are high or the higher order aberrations are high, you know that this patient is not going to be a fit candidate for a laser refractive for a premium IOL as such. This is the cornea and the lens densitometry. The other device which is similar to Pentacam is Galilei, which is basically same, but it has 2 shine plugs and it also has a placidose disc and gives you the same kind of data, but it has different software. So again, you have the total corneal power, you have the anterior chamber details, you have the total corneal aberrations, which it's given. So you can use this for your refractive surgery purpose. The other important tool when you combine a topography machine would be something to look at the corneal biomechanics, and Corvis is one tool which helps us combine the Pentacam data with the Corvis, and it gives you what we now know as corneal biomechanics index and total biomechanics index. And if this value is more than 0.67 in TBI, it indicates an active keratoconus where the cornea is biomechanically stable in spite of the topography being normal. Just one more example of the same. Eye tracy, where you can have both a ray tracing to get your aberrations and a placido device to get you your corneal curvature, helps you differentiate where the problem is, whether it is in the cornea, whether it is internal, and then you can treat the patient accordingly. It can also help you with respect to cataract surgery selection, because it gives you again the similar information with respect to your angle kappa. It tells you your spherical aberration, it tells you your intraocular aberration. So if a patient has a high degree of higher order aberrations, he or she would not be a candidate for a premium IOL. It is also useful in toric IOL because you can mark and you can decide on how much you have to re-rotate your lens if it is not in the correct axis. So to conclude, we do have multiple devices to look at the corneal curvature and the power. At this point of time, shine plug based devices are the most commonly used ones. OCT based devices might be the future. And these devices help us understand the optics of the cornea better and help us treat our patients in a much more appropriate manner. Thank you.
Thank you, sir, for that very elaborate talk. Topo has been a very perplexing topic for most postgraduates, so I'm sure it was very beneficial. We do have a few questions, sir. What is the preferred index for keratoconus screening amongst the list of indices that were described, sir?
There is no specific, there is no one test which you can say that if this value is positive, it is keratoconus. Basically, what we are looking at is a pre-refractive surgery. If it's a frank keratoconus, that's a totally different situation. What we are primarily looking at is a patient who comes for refractive surgery screening, and we look at the patient and we look at the maps. Yes, an elevation more than 16 is suspicious, but that alone might not be a cutoff. If there is any other thing, the pachymetric value is also thinner, the curvature is also on the higher side, or there is a definite increase in the elevation, or the biomechanics is taper. So it's not a single metric that can definitely describe it. You have to look at multiple points. Once it crosses the 49, once it becomes a frank keratoconus or a keratoconus suspect, then it's different. But you can also have a group of patients for what we call as formiferous keratoconus, where they have keratoconus in one eye, and the other eye, whatever data that we have today with respect to shine plug, with respect to biomechanics, with respect to topographer, shows the other eye as normal. So at this point, we are still not sure whether they are classified as a unilateral keratoconus or they are called as formiferous. The global consensus is keratoconus is bilateral, so they will be still classified as formiferous. So we do not have one specific matrix. But if you're looking at a Pachy less than 450 in a normal individual, that's highly uncommon. So you need to be a little bit careful.
Okay, but in terms of like a Kiza index or any of the other indices,
nothing. There is no single test which can classify. I mean, frank keratoconus will be positive in all.
Okay.
The problem comes when it is a subclinical keratoconus or a formiferous keratoconus, where everything becomes dicey. You also have the option of using epithelial map. Sometimes that also masks keratoconus. So you have the option of doing Artemis enabled epithelial map, which gives you a donut pattern suggestive of keratoconus, or you have the present generation OCTs, which also give you an epithelial mapping, which can probably help you find that the area of your cone, the epithelium is thinner, the periphery is thicker. So that's the reason why the topography is not picking up the keratoconic state. But no per one investigation is foolproof.
Okay. And how do we identify skewed radial axis, sir?
Basically, skewed radial axis is if you have a symmetric bow tie, you know the axis goes directly straight through both the arms of the 8. The moment the 8 tends to sag, you have one arm which is going through the lower portion and the other arm going through the upper portion. And if that angle is more than 20, it indicates a skewed radial axis.
There's one more question, sir. What is CME and what is the significance of that?
CME, basically, everything was, since we started off with keratometer, when the topographers came in, they wanted to replicate what keratometer does. So keratometer gives us the keratometric value at 3.2 mm. So this gives us the keratometric value at 3 mm using the 7th to the 9th zone. So it is similar to what you would get with a manual keratometer or an auto K. Having said that, none of the machines will have the absolutely same values. You will see some difference in all machines.
Thank you so much, sir. I think we don't have any more questions, so we can move on.
Thank you.
Thank you for joining us.
Thank you so much, sir, for that brilliant talk. Our last speaker for today is Dr. Arup Chakrabarti, the director of Chakrabarti Eye Center, Trivandrum. Sir is an active member of AIOS and is the president-elect of KSOS. He is a master of complicated cataract surgery and is the go-to person for cataract surgery and skill-based training for postgraduates and young ophthalmologists across the country. He has designed and headed over 200 instruction courses for cataract surgery and advanced training. He also has multiple textbooks in cataract surgery and is an awardee of AAO and ASRCS. I request you to educate us all on cataract evaluation, sir.
Today, cataract surgery is a therapeutic as well as a refractive procedure with truly outstanding outcomes. Though there are a number of reasons for this healthy scenario, a meticulous state-of-the-art preoperative workup plays a key role. This presentation will focus on a few relevant and cherry-picked aspects of the preoperative diagnostics, which have given me consistently good outcomes. In the interest of time, I may not elaborate upon how to actually perform these tests. I will also not be touching upon the routine battery of preoperative tests, and I suggest you look this up in any standard textbook of ophthalmology. Though I will be confining myself to preoperative ophthalmic workup, systemic evaluation is very important for the overall safety and well-being of the patient, and hence this aspect should never be ignored. Before embarking on biometric evaluation, it is important to look for evidences of concomitant ocular surface disease and blepharitis. We have known over the last several years the significant role played by an optimized ocular surface for precision in the biometric parameters. An irregular surface may be associated with erroneous keratometry reading, which in turn is likely to impact IL power calculation. Likewise, inaccurate topography and keratometry may lead on to imprecise location of the steep axis and may mar the toric IL calculations. Hence, it is important to stabilize the ocular surface before biometric evaluation. Biometry is usually repeated till consistency and repeatability of the morphometric parameters is confirmed. By the same logic, biometric evaluation ought not to be done after any contact procedure like applanation tonometry or gonioscopy, or for that matter, even a dilated evaluation. Pristine virgin cornea gives the most precise results. Hence, I would prefer to call the patient back on another day for the biometric evaluation. Should we be using lubricating eye drops before keratometry? Well, lubricating eye drops influence the K readings significantly, especially in ocular surface disease patients, and this effect is greater with higher viscosity drops. So, as per the guidelines in a recent publication in the American Journal, one should wait for an interval of at least 5 minutes before performing the keratometry. Keratometry can be performed with any of these devices. I use the auto keratometer feature of an optical biometer. For toric IOLs, I recruit multiple keratometry devices, which also includes a topographer, which helps me determine the nature of astigmatism and also astigmatic axis in borderline situations. When confronted with disparate readings, it may be worthwhile repeating the keratometry after optimizing the ocular surface. Optical biometry is the gold standard for obtaining the axial length. Alternatively, an immersion A scan can also be used, which delivers very precise outcomes. Contact A scan is no longer recommended for axiometry. Swept source based next generation optical biometers have additional features, including total keratometry and updated formulas, in addition to a few more, adding a different dimension to biometry. Can devices of the same class be used interchangeably? Well, this study has displayed high levels of repeatability and agreement while comparing the Aladdin and the Lenstar. Hence, it is believed that the devices may be used interchangeably in normal eyes. While it is always desirable to upgrade to the newer available technology, it is heartening to note that a previous generation non-swept source OCT based optical biometer has compared quite favorably with the swept source OCT based ones, displaying an excellent agreement between these two devices. Though Ironmaster 700 was more effective in obtaining biometric measurements in eyes with dense posterior subcapsular cataract and dense nuclear cataracts. It is still possible to mess up the biometric precision and accuracy even if one is using optical biometry if the obtained values are not properly validated. The measured values should be validated against the validation guidelines provided by the manufacturer or evolved by the practice, and erroneous or suspicious values should be deleted and repeated. Expert surgeons also must be experts in the area of preoperative measurements. Many of us may be familiar with this slide depicting a mix of formulas, both old and new, that have been used over the last couple of decades. Prediction accuracy of most of these are dependent on relative ocular morphology and all perform very well within the normal ranges of differential measurements. Few formulas are known to not do well at the extremes of the axial length. These are my go-to formulas, Barrett Universal 2 and Hill RBF, though I always have a look at the other older formulas in borderline situations. It is interesting to be aware of the newer formulas in the horizon, which have been very promising in the preliminary publications. We are all aware that macular status should be meticulously evaluated before undertaking cataract surgery, not only for presbyopia correcting lenses, but also for standard monofocal lenses. Dilated fundus biomicroscopy has been the standard of care since time immemorial, but we should know that this alone may not be enough in many situations. This test is known to have low sensitivity in the presence of advanced lens changes. There is also a likelihood of missing macular lesions or at times under-assessing the severity of the lesions. I learned it the hard way quite some time back, and let me share my experience. Quite some time back, we had a 70-year-old female patient, mother of a doctor cum IS officer, present to us for evaluation of her cataract. She was found to have a 3+ nuclear sclerotic cataract with posterior subcapsular changes. Macula appeared to be normal, even the OCT was normal. However, she did not have the surgery done immediately, returned after a couple of years. By that time, her vision had dropped to hand movement, and we felt that the vision loss was disproportionate to the amount of cataract. So we advised her to undergo a preoperative OCT, which she did not want to get done, and she already had an OCT done elsewhere, and gave us the OCT printout, which appeared to be normal. This was an old OCT printout. Postoperatively, she regained a vision of only 6/18, and this was quite embarrassing for us. So when we saw the fundus, patient had a macular hole, and this is what we saw in the OCT. So it has become one of the guidelines in our setup to perform macular assessment with a SD OCT in all cataract surgery patients in the preoperative period, particularly for patients who have a visual loss that is disproportionate to the degree of the cataract. And we always insist on a very recent or a fresh scan, and we do not accept an older scan printout. The patient subsequently underwent macular hole surgery in our center. She did extremely well as far as anatomical result is concerned, had near normal visual recovery. So the ending was happy, and we definitely were left much wiser from this entire experience. There has been a plethora of research papers on the merits of OCT-based macular evaluation. Many of these papers have held the view that macular OCT is superior to a biomicroscopic examination in detecting macular abnormalities in this population. The rates of clinically missed macular pathologies are known to vary from 4.9% to 25%. Epiretinal membrane and age-related macular degeneration being the most common pathologies. And risk factors for the abnormal OCT scan include older age and diabetes mellitus. Most of us would be wary of performing presbyopia correcting IOL implantation without a macular OCT because of the risk of a potential decrease in the postoperative quality of vision. But what about routine preoperative SD OCT for all cataract patients? In a very recent January 2021 JCRS publication, preoperative SD OCT scans picked up clinically significant macular pathologies in 40.6% of the eyes. In almost two-thirds, that is 64.1% of these eyes, macular pathologies were either missed or underestimated by the preoperative fundus biomicroscopic examination. The rate of missed macular pathologies in this study population was 22.8%, with AMD being the most common pathology, followed by ERM. These are the case examples from the same publication. In all these four eyes, A, B, C, D, definite macular pathology had been missed by dilated fundus biomicroscopy, but picked up by the SD OCT. The role of preoperative macular OCT is beyond controversy for presbyopia correcting intraocular lens surgery. Macular SD OCT is also useful in detecting overlooked macular pathologies or to better assess the severity of a known macular abnormality in patients before cataract surgery. The preoperative OCT outcomes may help optimize the surgeon's clinical judgment and appropriate therapy if needed. It may also alter the surgeon's surgical strategy. For example, the surgeon may like to combine the cataract surgery with an anti-VEGF or steroid injection, or in certain situations, the surgeon may like to combine cataract surgery and the retinal procedure in the same sitting. This strategy will also improve the informed consent process and offer patients a more realistic expectations. Further studies are required to assess the cost benefit of incorporating this examination into our routine preoperative protocol. For very advanced cataracts, both modalities of fundus evaluation will not work. B-scan ultrasonography comes to our rescue in those situations. One word of caution, B-scan will only inform us about gross pathologies involving the posterior segment and may not reveal the subtle changes. As a cataract surgeon, it is good to have some idea about what to look for and how to interpret the common posterior segment pathologies rather than depend solely on the ultrasonologist. Point echoes are seen in the presence of vitreous hemorrhage, detection of which may change the surgical game plan. So, instead of performing a simple cataract surgery, the surgeon may change his plan and perform a combined phaco-vitrectomy. High reflectivity point echoes are also noticed in association with asteroid hyalosis. Presence of asteroid hyalosis may render biometry a bit inaccurate and is also a risk factor for posterior capsular rent. Dense asteroid hyalosis may be an indication of adding vitrectomy to the cataract procedure. How do we work up patients who complain bitterly about poor quality vision with normal or near normal Snellen vision and very faint lens changes? This is not an uncommon breed in our practice, and let me illustrate with an example. A 58-year-old diabetic and hypertensive lady with ocular surface issues presented with blurriness, actually 6/6 and N6 with minimal correction, and grade 1 nuclear sclerosis with very early peripheral cortical lens changes. The clinical features of this lady can be explained by DLS, that is dysfunctional lens syndrome, a term first coined by George Waring and published in 2013. Dysfunctional lens syndrome can be assessed with a device, ray tracing aberrometer, eye trace, manufactured by a company called Tracy Technologies. In this connection, three features are studied in the dysfunctional lens display of the eye trace: the Snellen E, dysfunctional lens index, the DLI, and the total eye opacity map. We also make a note of the angle alpha and the higher order aberrations. The Snellen E in the total eye panel of the DLS display looks quite blurred in the left eye. The DLI is 7.12 in a scale from 0 to 10, and the total eye opacity map shows grade 1 in a scale from 0 to 5. Based on the patient's visual complaints and supported by the DLS workup data, we performed phaco-IOL in the left eye, and the results, as you see, are very gratifying. This vindicates the role of DLS assessment in the overall decision-making process. Optical alignment and its measurement assume great significance in this era of presbyopia correcting intraocular lenses. It is held that angle alpha is important in this context. Angle alpha is the distance between the red cross hairs, which indicate visual axis, and blue cross hairs, which indicates center of limbus. Since intraocular lens tends to center on the limbal center, regardless of the intraoperative centration maneuvers, and not over the visual axis, in the presence of a large angle alpha, the visual axis doesn't pass through the IOL center, and this may spell trouble in the presence of a multifocal intraocular lens. Since the visual axis passes through the diffraction rings and the vision may get compromised, resulting in potential complaints, blur, double vision, halos, etc., a better option may be a monofocal IOL with a large sweet spot. A presbyopia correcting IOL with a radius of the central button greater than angle alpha value, if available, may be more desirable. I must hasten to add that there is another school of thought that makes little of the concept of angle alpha and its influence in multifocal IOL technology, IOL selection, and or postoperative patient dissatisfaction. Let me illustrate this point with an interesting patient. A 58-year-old female patient, gynecologist, presented to me with a visual discomfort, though her vision was improving to 6.6 and N6 with small correction. And she was found to have anterior and posterior subcapsular lens changes. So when I put her on the eye trace machine and used the dysfunctional lens patient display, we noticed that both eyes, the Snellen E was pretty much blurred. The dysfunctional lens index was 2.48 in the right eye and 2.70 in the left eye. That is quite significantly affected. And the total eye opacity map in the right eye had grade 2.0 and left eye also had the same amount of opacity grade. So definitely she is likely to benefit from cataract surgery. She was desirous of multifocal intraocular lens, so I calculated the angle alpha, and it was there's a red flag in the right eye and left eye is okay. But since multifocal IOL technology is always used bilaterally, and I had a relative contraindication for her multifocal IOL for the right eye, I decided not to use a presbyopia correcting intraocular lens, went ahead with a monofocal intraocular lens, performed phacoemulsification, and she has been a very happy patient. Risk stratification is another important exercise that our team engages in while scheduling a cataract patient for surgery. This strategy offers multiple benefits. It renders the preoperative patient counseling more meaningful and objective. It alerts the OT to gear up for unusual intraoperative events, allows the surgeon to self-evaluate against a standard benchmark and initiate corrective measures if called for, and it also suggests appropriate case allotment depending on surgical expertise and seniority, especially in a teaching hospital. There have been a number of risk stratification models described in the scientific literature. A few of these are mentioned in this slide, and in one of these I had been a participant as a surgeon. One of the widely followed risk models is that of Mutaseb, which was published in BJO in 2004. I have been following an individually customized version of this model. Points are allotted to each risk factor depending upon the weightage for each risk factor in the peer-reviewed literature. As you see here, there are three categories of allotment of points or score per risk factor, and each risk factor in category B earns 1 point, whereas in category C, each risk factor earns 3 points. Based upon the cumulative score, a surgical patient is grouped into one of 4 groups, with group 1 having no risk and group 4 high risk. As you can see here, the complication rate increases from 4.32% in group 1 to peak at 32% in group 4, which is the high risk group, with overall complication rate being 7.1%. The serious complication rate, for example, posterior capsular rent, vitreous loss, zonular dialysis, incomplete rhexis, etc., seems to increase through the groups as the risk status increases. The Mutaseb model has been validated in many subsequent studies, and more advanced models have also been proposed. So, friends, in conclusion, satisfactory outcome in modern cataract surgery depends upon proper care of the systemic issues, a very thorough, meticulous, and exhaustive preoperative workup and tests, and attention to the state-of-the-art diagnostics, a few of which I have discussed in my presentation. Thank you very much for your attention.
Thank you, Arup sir, for that wonderful discussion on a very important topic which all PGs should know. So, cataract surgery is the most common surgery that an ophthalmologist, it is the bread and butter of ophthalmology. So, we will look at the questions which are coming in. So, one question which most PGs will ask, which has been asked here is how to differentiate between posterior subcapsular cataract and posterior polar cataract.
Yeah. So I think it is quite a good question. So there are certain issues with the posterior polar cataract. See, it is confined exactly in the axial area, and it is very well circumscribed. And when it progresses axially forwards. And in association with this cataract, you can see some powdery white deposits. You may see some oil droplet-like structures in the anterior vitreous. You can even see a spindle-shaped defect originating from the center of the posterior polar cataract. So this is what you see clinically. And sometimes, when you see a posterior polar cataract in one eye, you're not very sure whether it is a posterior subcapsular or a posterior polar cataract. You have a look at the fellow eye. And if the fellow eye happens to be aphakic, or if it is pseudophakic with a PC rent, then you can assume that the particular eye that is in question also has got a posterior polar cataract. And certain investigations can be done. For example, if you do a B scan for these patients, 10 megahertz probe may not really help you that much. To a certain extent, yes. But if you can get the 20 megahertz probe, which the gynecologists are using, now you can definitely see what's happening in the area of the posterior polar cataract, the area just behind the posterior polar cataract, posterior capsule, whether it is intact or it is not intact. And then, of course, with anterior segment OCT, we can definitely get a much better picture about idea about whether it is a posterior polar cataract and it has a congenital posterior capsular dehiscence present or not. So I think it is very important for posterior capsular rent compared to a routine cataract. Though the incidence of posterior capsular rent has come down drastically, but still, it's still higher than a routine case. So it has to be. We have to try to get this condition before the patient goes to the OT table, and a proper counseling is very, very important. You need to have the standby intraocular lenses, because sometimes you may not be able to perform a in-the-bag intraocular lens. So you may have to have an alternative lens which can be kept in the ciliary sulcus with posterior optic capture. So I hope I have addressed the issues pertaining to posterior polar cataract.
Yes, sir. That is very, very informative, sir. It is always important to be prepared for a posterior polar cataract. So if you're not prepared, then that is where the whole problem happens. Another question, sir, is about your opinion and experience with IOL monovision strategies.
See, with the advent of the advanced technology lenses, now you have these trifocal lenses that have come up. And that with that, we have been able to get rid of most of the visual complaints which were there with the earlier generation multifocal lenses. So I tend to now do more of multifocal lens technology when the patient is looking for it. However, this comes at a cost, and there are certain contraindications where a multifocal technology cannot be used. In that case, I ask the patient. Not all patients may be interested in monovision. Some patients get frightened when you give them the suggestion that one eye is going to be used for the distance and another eye for a near vision. So it all depends upon the patient psychology. So you have a proper discussion with the patient, and then go for a monovision only when the patient accepts that he is going to have, he may require glasses for a particular eye, glasses for a prolonged near activity. Otherwise, it is not a good idea to go for monovision if the patient really doesn't want it and doesn't know what exactly is to be expected. So I would prefer to use a trifocal lens in my practice when a patient doesn't have any contraindications and the patient can afford it.
Thank you, sir. That is important. Sir, suppose you already have done monovision for a patient and the patient is uncomfortable. Can we just correct it with glasses? Can we
Yeah,
correct
that
the
can be
mono?
done. Yeah, that can be done. So ultimately, you have to correct with the glasses whatever residual reflection is uncomfortable for the patient. That can be done.
Okay, sir. Another
That is done.
question. Yes, sir. So in case monovision doesn't work out, the backup is to give glasses
Yes.
and fix it back. Sir, another question is, what is the best way for marking axis for toric IOLs? Sir?
That's a very interesting question.
Cheapest
So,
and best.
yeah, I mean, see, once the toric lenses came into the practice, I have tried out all kinds of markings other than the digital marking. So, that is the markerless system. So, I basically today prefer to use the slit lamp based marking system for the patients. So, I put the patient on the slit lamp and then mark the axis where the lens is going to be, toric lenses is going to be aligned. Sometimes you really don't have to mark it, because when you approach the patient's eye with the needle or the Sinsky hook, the patient gets a little wary of it. They start blinking. So I just try to remember any pigmented patch or any conjunctival blood vessel in that particular area in the limbus, and I just remember it, and maybe I just make a note of it. And if there is none, then of course I just put a couple of spots on either direction, on either aspect of the limbus. And then I take the patient on the surgical table. And then I put with a 26 gauge needle 2-3 stromal marks on the limbus on the axis where the lens is going to be aligned. And this has worked out extremely well in my hands. And I really have not felt the need to use more marking methods for this.
That's excellent, sir. So that's like a manual variant, manual markerless system.
Yeah.
Sir, there's another question. If B scan is necessary, if fundus is very hazily seen, say in a near mature cataract, so fundus is seen but very hazy, should we do a B scan?
See, a B scan is going to pick up only the gross pathology. It is not going to pick up subtle retinal changes. So, if you are able to see the fundus, sometimes in patients with advanced nuclear cataracts, you can still see the fundus. So you don't need to have to you don't need to perform a B scan for those patients. But when you are not getting a good view with your whatever fundal examination technique that you're using, normally we use indirect ophthalmoscopy, and we are not getting a good view. In that case, a B scan has to be done, because if it's a diabetic patients with an advanced, coming at an advanced stage of diabetic retinopathy, patient has a vitreous hemorrhage, patient has a tractional retinal detachment. So you need to be prepared beforehand, before you take the patient on the surgical table. You should have a surgical game plan ready with you, so that post-operatively you don't land up in a surprise and the patient starts blaming you for not giving him proper information before surgery.
Thank you, sir. And sir, as you mentioned, preoperative OCT is also important. So if you want to give the
Absolutely.
best,
See,
so
initially I used to do preoperative OCT only for patients with who ask for a multifocal lens, an advanced technology lens. But a couple of years back, maybe about 10, 12 years back, I gave the example of a patient where patient was a very well-to-do patient, and daughter was a doctor and an IS officer. And when the patient came back to me for surgery, she had an old OCT report where everything was fine. The posterior segment was okay, but on the first day, when there's no visual recovery, no significant recovery, she got only 618. Then we saw a big macular hole. So, I mean, I think preoperative OCT, I do it routinely for all patients. If a patient can't pay, I do it complimentary. We don't charge the patient for that. But I think that's a very important test to be performed.
yes, sir. If we look at whether cost is not a factor, if we are looking at what investigations to do, I think macular OCT is to be definitely included.
Yeah.
Sir, another question is about specular microscopy prior to cataract surgery. Should it be mandatory for all older patients?
No, I don't think specular macroscopy is really mandatory, though I do it routinely for all my patients. See, it is important. It is important for you to, supposing if a patient has come to me with pseudophakic bullous keratopathy in the other eye, and then I examine the eye to be operated very carefully, and most of the time you see that they have advanced guttate changes, Fuchs dystrophy is present, so that is a different category of patients. But for a routine patient, I examine the corneal endothelium under the zone of specular reflection, and you can get a lot of information from that. You can see those hexagonality, you can see the the corneal guttate changes, so then all those deposits. So that gives a fairly good idea. Then I also do a specular microscopy because it gives at least 100 times magnification than the slit lamp view, whatever slit lamp that we're using. And then it gives you the endothelial cell density, the coefficient of variation, and then you also have a document. It is documented. So post-operatively, you have if it is a patient with a very borderline cornea, you already have documented that the patient had a very unhealthy cornea. So it saves you at the end of the day. But I also perform a pachymetry for all my patients because that is also that is very useful for, pachymetry is an important factor in the metrics when you take up a patient for cataract surgery with coexisting morbidities like, endothelial dystrophy and, those Fuchs dystrophy. So then depending upon the pachymetry value, and there are a lot of other factors, so we decide whether we'll do only cataract surgery or it will be done, or it will be a cataract surgery combined with a lamellar keratoplasty, posterior lamellar keratoplasty.
Thank you, sir. So slit lamp examination has to be thorough. So with that, you would not probably need. There is one more question. I think we are short of time, but let's just see this. So zero lens power or low lens power or aphakia for high myopes, should we for high myopes, if we calculate and get a power of 0, should we put a lens or do we just leave it aphakic? That is the question, sir.
I think that is a very interesting question. And I mean, we have been thinking about it right from the time I was a postgraduate student and a fellow. So it is always a good idea to implant an intraocular lens, even if it has a very low positive power or 0 power or negative power. In fact, next week, I'm going to do a patient who has got -6 diopter lens. It's a meniscus lens. So the important things here is, you have to calculate the lens power properly, use the Barrett, universal 2 formula for calculating the lens power, do the surgery under topical anesthesia, because if you try to block these patients, then, there may be posterior staphyloma and you may end up with low perforation, and use a lens because that reduces the incidence of posterior capsular opacification. It delays, it reduces as well as it delays. Plus it also stabilizes the posterior capsule, and it is definitely a more desirable option than to keep the patient aphakic.
Thank you, sir. So that is very important. Sir, one last question. Contraindications of multifocal IOL. So as you were saying, you are using multifocal IOLs. So which patients are contraindicated for multifocal IOLs?
Exactly. I mean, actually, it is an entire topic. You could talk about it for quite some time, for maybe 10, 15 minutes. So when I started multifocal lenses, I was with Dr. Howard Fine, and he told me that, if a patient asks you more than 3 doubts, he is not a candidate for multifocal IOL. All right. Of course, this is an exaggeration, but in my practice, I do about maybe 8 to 12% of my entire cataract surgery is multifocal lens, because when you have to be very choosy about these patients, they should have no associated comorbidities. Patients with ocular surface disease, patients with corneal problems, patients with retinal problems, epiretinal membrane, or diabetic patients with progressive diabetic retinopathy, or even no diabetic retinopathy, but it may progress. And patients, amblyopic patients, patients with squint, patients who are extremely demanding. So those patients basically are not going to be happy dealing with the dysphotoxic problems that most of these patients have because of the lens design, the glare, halo, and blurring effect, etc., etc. Though the incidence has come down drastically with the newer technology lenses, but they still persist. So this would be some of the contraindications for not using a multifocal lens in my practice.
Thank you, sir. So one last question. So A-scan biometry in pathological myopes with fundus changes, is it a challenge?
It is definitely a challenge, So A-scan biometry, when you have pathological myopia, posterior staphyloma, it is indeed a challenge. So first thing first, I was not sure whether you listened to my talk properly. A contact A-scan biometry should not be performed. You should always perform an application A-scan biometry. Now, that is with immersion biometry. Now, many of these patients have posterior staphyloma, and the fovea may be lying on the slope of the staphyloma, not at the bottom of the pit. And if you have not done a proper, if you have not followed a proper technique, then you may be ending up measuring the distance up to the floor of the staphyloma, and that's going to give you a very false axial length. So that has to be careful, and sometimes you may have to locate where the fovea is by doing a by B scan. So that your machine should be equipped to perform that. So to eliminate this error, and it is always better to use an optical biometer in this sort of cases, so that the chances of making error is much less. In fact, the swept source OCT based optical biometers, ILMaster 700, you can see the fovea where exactly the length is being measured. So that definitely reduces the chances of error in axial length biometry in these cases.
Thank you so much, sir, for that wonderful talk and discussion. I will hand over the mic to Dr. Narayan.
Thank you very much, sir, for that informative session. It's changed our view on cataract surgery from now on, and it's high time we all switch to a IOL master or any other type of non-contact machines.
The
Thank you so much,
immersions,
sir.
you don't have to, one doesn't have to spend so much money if he doesn't want to on optical biometer. You can do the immersion biometry, that is immersion scan, that is very, very accurate.
Right, sir. Thank you so much, sir. Thank you so much for the informative session. I hand over to...
just a small interruption. Dr.
Hi,
Arup,
Suhas, how are you?
I'm doing good. It is so nice to hear you back again, Dr. Arup. And as usual, you've been fantastic. It was so absorbing session that I heard from you. And of course, I always look forward to your lectures in all sessions in scientific forums. And as I was telling my postgraduates, definitely this is something that they all look forward to. And I think you lived up to the occasion. Thank you so much. It was a very absorbing.
Thank you. So this was a big topic. Maybe one of these days I'll make a 1 hour. You can talk on 1 hour. On this pre-op workup. So maybe I'll just make a separate video for your PGs and send it to you.
Oh, that would be lovely. Thank you. We should also like to have you also personally, if time permits, for you to have a talk in our institution. When you can come, we'll invite you. Thank you so much. Thank you. Thank you, Narayan.
Okay,
thank you, sir.
Thank you.
I'd like to request Arvind Babu, sir, to conclude the CME and the future ahead.
Thank you, Narayanan. So we have come to the end of this wonderful session. Once again, I would like to thank all our eminent guest speakers for taking out time from the busy schedule and enlightening us with their knowledge. Thank you so much. I would like to thank our HOD and Medical Director, Professor Suhas Prabhakar, sir, for being a constant encouragement and support for all of us. I also thank our coordinators, Dr. Narayanan, Dr. John, Dr. Gayatri. They really worked hard to make this event successful. Last but not the least, I would like to thank Microvision Microlabs for supporting us. Thank you, Mr. Navneet. Thank you, Mr. Amit, and thank you, Mr. Solomon.
Sir, our pleasure, sir.
Thank you, sir.
We'll do a lot of CMEs in the future.
Sure.
So wish this was helpful to all the students who are participating, and they can also watch us on YouTube, Srihar Ophthalmology channel, and wish you all good luck. Let's meet in the next webinar, the webinar 3 and the PG update. Thank you. Have a good day.
Shall I end this one, sir?
Yes, please. Go ahead.